In this chapter, we will discuss basic principles of skull-base surgery. Preoperative planning is a critical step in preparation for surgery. This includes counseling the patient and family on expected and potential outcomes, risks, and benefits, expectations before and after surgery, including length of stay in the hospital, and risk for cranial nerve injury or other associated deficits. Preoperative medical risk evaluation, workup, and imaging should be performed as appropriate on a case-by-case basis. This may include CT, MRI, angiography, or consultations from multidisciplinary teammates, including referrals for auditory or visual field testing, and evaluations by otolaryngology, ophthalmology, or endocrinology, among others. It is helpful to discuss pre- and postoperative medications that patients may expect to take, including dexamethasone, antiepileptics, desmopressin if at risk for DI, or other medications including the expected pain regimen. Preoperative imaging may include any of the following. CT scans with thin 1 mm cuts help to detail osseous structures. This may be helpful in identifying hyperostosis, temporal bone anatomy, the pneumatization of air sinuses, or in some cases may help localize a CSF leak. Fat-suppressed T1 MRI reduces the high intrinsic signal from bone marrow to highlight contrast enhancement. DTI may be helpful in identifying displaced white matter tracts. CT or MR angiography or venography delineates important vascular structures along the operative corridor and in the vicinity of the tumor. Catheter angiography provides dynamic vascular imaging and may be combined with embolization to facilitate surgical resection in certain cases. Skull-base lesions often progress to large sizes by the time patients come to neurosurgical attention. The question of timing of surgical intervention is dictated by the quality and rate of progression of the patient's symptoms. Symptoms that seem to progress day to day should alert the surgeon that the patient may be at risk for rapid decline, as the volume of intracranial pathology increases and further displaces normal intracranial contents. There is an associated increase in intracranial pressure, which is initially well compensated for. As the patient nears the point of compensatory loss, additional small increase in tumor volume results in significant increase in intracranial pressure and rapid neurological decline. Although emergent intervention is rarely warranted for skull-base pathology, there are some important exceptions. Acute hemorrhage into a lesion can result in acute onset neurological decline, necessitating surgical decompression, a prime example of which is pituitary apoplexy. Similarly, pathology resulting in obstruction of the normal flow of spinal fluid, such as third ventricular colloid cysts, can result in hydrocephalus with acute decompensation, requiring emergent CSF diversion or tumor resection to reestablish normal flow. Certain pathologies, such as skull-base meningioma and acoustic neuromas, are associated with communicating hydrocephalus, which may similarly manifest with acute decompensation. There are a handful of cardinal surgical approaches that allow access to the vast majority of pathology at the skull base. These approaches are often modified according to the individual surgeon's experience and comfort level and the goals of surgery. Nonetheless, these modifications remain variations on the main corridors. The anterior skull base is often approached endoscopically, but may also be approached via bicoronal or subfrontal approaches. The middle cranial fossa approaches include the subtemporal approach and the pterional approach and its variations, including the orbitozygomatic craniotomy. The posterior fossa approaches can be divided in relation to the sigmoid sinus. Presigmoid approaches include the retrolabyrinthine, translabyrinthine, and transcochlear approaches, and retrosigmoid approaches include the standard retrosigmoid craniotomy, as well as the far lateral approach and the midline suboccipital craniotomy. The pterional approach was pioneered by Yossergill in the 1970s and is considered the standard approach to anterior circulation aneurysms as well as pathology of the cavernous sinus. In addition, the approach affords an excellent view of suprasellar lesions, such as large pituitary adenomas and craniopharyngiomas, as well as petrous apex meningiomas and lesions at the upper clivus. At its core, the approach produces a bone flap that allows access to the frontal lobe, temporal lobe, and the sylvian fissure. Typically, a curvilinear incision starting approximately 1 cm anterior to the tragus and extending behind the hairline to the midline or just past the midline is used. The temporalis muscle is either elevated along with the skin using the so-called myocutaneous flap or dissected separately. When dissected separately, the frontalis branch of the facial nerve is protected by use of an interfascial or subfascial dissection. A burr hole is placed at the keyhole, and additional burr holes are placed according to the planned extent of the craniotomy. The approach has several advantages, including the need for minimal brain retraction, short distance to pathology, and multi-directional views. Variations include an orbital osteotomy, zygomatic osteotomy, or orbitozygomatic osteotomy. Bilateral transbasal approach may be adopted for certain lesions in the anterior fossa. A bicoronal incision with a 1 or 2-piece craniotomy medial to the superior temporal line on either side may be used depending on the size and location of the lesion. Variations include removing the orbital bar with bilateral orbitofrontal or orbitofrontoethmoidal osteotomies to access the anterior cranial fossa. An alternative to the extended transbasal approach is the endonasal transsphenoethmoid approach. Unilateral approaches can be performed with a bicoronal, curvilinear, or eyebrow incision, and may provide access to midline anterior cranial fossa meningiomas, sella, and suprasellar pathology. The use of the endoscope allows further access to the third ventricle, the anterior medial temporal lobe, and the middle fossa. The anterior transpetrosal transtentorial approach, often referred to as Kawasi's approach, allows for the visualization of surgical pathology behind the petrous apex while minimizing injury to the temporal lobe and the acoustic apparatus. Classically, a horseshoe incision with a craniotomy above the mandibular joint is employed, but many variations have been described. The craniotomy is made flush with the floor of the middle fossa, and important landmarks including the middle meningeal artery, greater superficial petrosal nerve, and the arcuate eminence are identified. Kawasi's triangle lies among the trigeminal impression anteriorly, the arcuate eminence posteriorly, the major petrosal groove laterally, and the carotid canal inferiorly. In the classic description, the superior petrosal vein is sacrificed. This approach can be used to access basilar tip aneurysms or large petroclival meningiomas. The anterior petrosectomy can be combined with a posterior petrosectomy, and the combination of the two procedures is referred to as a total petrosectomy, pioneered by Al-Mefti. It is the approach of choice for many surgeons dealing with extensive petroclival meningiomas. The retrosigmoid craniotomy is a powerhouse approach for access to the posterior fossa. It is one of many approaches to the posterior fossa, but is perhaps the most versatile. Once completed, the approach affords excellent visualization of the contents of the infratentorial compartment, as well as some supratentorial structures starting at the level of the oculomotor nerve. The trochlear nerve, the tentorium, and the tentorial incisura, and cranial nerve 6 to 12, from their exit at the brainstem to their entry into the skull base, are well visualized. In addition to the neural structures, vascular anatomy that is well visualized includes the mid-portion of the basilar artery and the anterior inferior cerebellar artery, or ICA, as it relates to the 7-8 complex. The pathology dictates how much exposure of the venous sinuses is necessary, and additional bone may be removed as needed. The retrosigmoid craniotomy has been well described for access to the cerebellopontine angle, including for resection of vestibular schwannomas. Visualization during today's transsphenoidal approach can be accomplished with the microscope, the endoscope, or both, and is often supplemented by the use of three-dimensional stereotaxy. The basic endonasal transsphenoidal approach often begins by harvesting a nasoseptal flap, of which a variety of shapes and sizes can be obtained. This is followed by exposure of the face of the sphenoid sinus by removing the overlying mucosa. Once exposed, the face of the sphenoid sinus is open using a high-speed burr, and the contents are widely exposed. For removal of a pituitary lesion, the exposure should extend from the planum recess to the clival recess in the sagittal plane, and from cavernous sinus to cavernous sinus coronally, including both optico-carotid recesses. Once these landmarks have been identified, an opening can be made in the floor of the sella for removal of the tumor. Reconstruction of the defect can be achieved with a variety of allograft and synthetic materials and various glues and sealants. The nasal cavity can be optionally packed for a short period postoperatively. Although each position has its nuances and multiple variations, and surgeons have particular preferences regarding the execution of each position, there are some important overarching principles. First, the patient's position should not place any body part in a non-anatomic position that would not be well tolerated if the patient were awake, such as forcefully turning the head in the supine position instead of using the lateral position, or stretching the brachial plexus when using a shoulder roll. The incidence of brachial plexopathy following a lateral approach to the skull base is as high as 9% and is most often ipsilateral to the surgical site. Second, all pressure points should be carefully padded, which is especially important for lengthy operations. Typically, the elbows are completely wrapped to prevent an ulnar neuropathy. For patients in the supine position, the knees should be flexed and supported with a pillow to reduce stress on the lumbar spine. The eyes should be well protected, and the external ear canal is protected from ototoxic skin preparation solutions such as betadine. Third, adequate venous return should be ensured such that unnecessary venous hypertension is avoided. This is done by placing the patient's head at the level of the heart and ensuring that the neck is supple and not hyperflexed. Last, the patient and head position should be such that the amount of brain retraction is minimized. In general, the approach to the pathology should be perpendicular to the floor, which is also often the most comfortable position for the surgeon. The choice of anesthetic agents benefits from the experience of a seasoned neuroanesthesiologist. Certain hypnotic agents, such as barbiturates and propofol, reduce cerebral activity and can be used as neuroprotectants to induce burst suppression as needed. Volatile anesthetics also reduce cerebral metabolism, but are associated with venodilation, and some, such as sevoflurane and isoflurane, have epileptogenic potential. Nitrous oxide is typically avoided during craniotomies because it may worsen pneumocephalus. The incorporation of intraoperative neuromonitoring presents additional challenges. The use of muscle relaxants is avoided during the monitoring phase because they impair the ability to detect nerve integrity. Although brainstem auditory evoked responses, or BARES, are not significantly affected by the use of volatile anesthetics, somatosensory evoked potentials require their careful titration to avoid losing the fidelity of the signal. Spinal fluid diversion with intraoperative lumbar puncture or lumbar drain placement can aid in brain relaxation and may be helpful in many skull-based procedures, but is typically a matter of surgeon preference. Intraoperative stereotactic navigation allows for reliable identification of important structures as well as tumor boundaries. Its use has been shown to reduce operative times and to result in fewer major complications and shorter hospital stays. Image guidance systems allow the surgeon to identify tumor margins, to plan the ideal angle of attack, to visualize normal anatomic structures en route, and to provide guidance regarding remaining tumor depth during the course of intracapsular tumor debulking. Intraoperative navigation has been especially useful in the development of the field of minimally invasive and endoscopic skull-based surgery. Over-reliance on the intraoperative image guidance system, however, is ill-advised, and the system is ideally used as a confirmatory modality in conjunction with standard anatomic landmarks. Intraoperative MRI may ameliorate the effect of brain shift during surgical exposure and tumor dissection and provides updated information during the course of resection. The field of skull-based surgery has evolved around the core concept that additional bone removal is preferable to brain and other neural structure retraction. The microscope revolutionized the field of skull-based surgery owing to its previously unparalleled ability to illuminate and magnify. It remains limited by the fact that it requires a direct line of sight to provide those advantages. Endoscopy, on the other hand, has the natural advantage of providing an angulated view with a narrow line of approach with an up-close perspective of the surgical target under full illumination. However, endoscopy has its own limitations and has yet to be fully adopted. Nonetheless, it remains a useful adjunct tool in the armamentarium of skull-based neurosurgeons. The most frequent complication of skull-based surgery is CSF leak and infection. The most effective way to combat CSF leak is via primary prevention, a watertight dural closure with selective use of dural substitute and dural augmentation materials, and the provision of adequate soft tissue coverage. When primary prevention fails and CSF leak occurs postoperatively, it must be managed in a timely fashion to prevent downstream infection-related issues. Reconstructive strategies, CSF leak repair techniques, and issues related to venous injury and repair should be studied in detail. Core principles in skull-base surgery that help reduce postoperative complications include cranializing the frontal sinus when it is exposed to prevent future mucocele formation, creating a durable barrier when an air sinus is exposed to separate the intracranial contents from the extracranial world. Whenever possible, the intradural space should be closed by process of dural repair before exposing contaminated portions of the field, including the air sinuses and the nasopharyngeal cavity. Fibrin glue and dura overlay materials do not replace meticulous dural closure techniques. For open surgical approaches, continuous spinal fluid diversion is one effective treatment modality with success rates exceeding 85%. In instances where CSF diversion has failed or is not expected to be successful based on the perceived leak rate, surgical exploration and primary repair of the leak site is a viable option. In those circumstances, it is often advisable to further augment the suture line with autologous fat graft that is secured in place with several 4O non-absorbable sutures, overlaid with fibrin glue and reinforced with Surgicel or gel foam. Other strategies, such as the use of hydroxyapatite cement cranioplasty, have also been reported with success. For transsphenoidal approaches, the development of a vascularized nasoseptal flap has dramatically reduced the rates of CSF leak, with modern series using the flap reporting leak rates of 5 to 6%, with a drop from an initial 14 to 4%. Other reported flap reconstruction techniques included free turbinate flap, a pedicle inferior turbinate flap, a transpositioned pedicled temporoparietal fascia flap, and a pericranial flap. Skull-base craniotomies are often made within the vicinity of major dural sinuses, or deal with pathology that abuts or invades a major dural sinus. As a result, there is a looming risk of venous injury with these procedures. When such an injury occurs, the first priority is to prevent the occurrence of a venous air embolism, which is done by flooding the surgical field with irrigation and lowering the patient's head via a Trendelenburg maneuver such that the head is positioned below the patient's heart. Once that is done, attention is turned to repairing the defect. Hemostatic agents such as Surgifoam and Floseal should be avoided because they are more likely to result in sinus occlusion or a thromboembolic event owing to their particulate nature. For small, less than 5 mm dural sinus violations, a similarly sized piece of gel foam can be carefully laid over the defect, taking care not to insert it into the sinus itself. Pressure can be applied atop the gel foam using a neurosurgical cotton patty and a sucker for several minutes. Once this repair has taken hold, it can be cemented into place using a small amount of fibrin glue. For larger dural sinus injuries, the size and configuration of the injury should be carefully examined, and a decision made regarding patching or bypassing the sinus. Bypass is rarely needed and rarely done. When it comes to patch repairs, many techniques have been described. One preferred technique is as follows. Control of sinus bleeding is achieved by placing long strips of Surgicel into the defect. If available, temporalis fascia is harvested and used to repair the defect using 8-O-proline. Otherwise, pericranium or even dura can be used. Once the repair is nearly completed, the piece of Surgicel is removed and the repair finished. Postoperatively, attention should be paid to the patency of the affected sinus. Patients with non-occlusive thrombi likely benefit from treatment with prophylactic dose low molecular weight heparin once deemed safe from a surgical perspective, whereas patients who have had a patch graft are typically placed on anticoagulation for 3 months postoperatively.